Bismillahirrahmanirrahim. This is the screencast for the lecture number 22 regarding the pleural diseases, pathology of pleural diseases. After this lecture, I expect the students will be able to tell about the various clinical pathological conditions causing pleural effusion, and they can able to describe it, and able to understand the pleuritis, and they can able to describe the pleuritis, and they can able to compare and analyze the various clinical outcome of pneumothorax, hemothorax and chylothorax, and they be able to describe the morphology of pleural tumors and its clinical outcome. Okay, so now let us discuss first about pleural effusion, which is very important. And pleural effusion means the fluid increase in the pleural space, which means normally the pleura has fluid which is about 15 ml, and the nature of the fluid is serous and relatively acellular, and they have clear fluid. Function is they serve as a lubricant, and they also maintain some negative pressure, so and it involves in the process of ventilation. Okay, so now this increase in pleural fluid in the pleural space is maybe primarily due to some pleural diseases or secondary pleural diseases. Secondary pleural diseases means the other systemic disease which affect the pleura, or the primary disease which is the disease happening in the pleura itself. Okay, so it may be due to inflammatory and non-inflammatory condition. Inflammatory means pleuritis, inflammation of the pleura, infection of the pleura. Whereas in non-inflammatory, example, a cardiac disease producing pleural effusion. Example, congestive heart failure. So like that, they are non-inflammatory condition. Whereas inflammatory condition, the pleural effusion is different. In non-inflammatory condition, the pleural effusion is different. So these are the major clinical settings which alters the mechanism. These are the major clinical settings which alters the mechanisms that leads to pleural effusion. So what are they? Congestive heart failure, which alters the mechanism of hydrostatic pressure. What is the alteration? They increase the hydrostatic pressure. Okay, that leads to pleural effusion. Whereas in pneumonia, the alteration happens in the vascular permeability, because the pneumonia causes acute inflammation. Acute inflammation, the first change is the vascular change that alters the vascular permeability, that increase. What is alteration? That increase the vascular permeability. Okay, whereas in nephrotic syndrome, what is the problem in nephrotic syndrome? They lose protein. When the protein is lost, that will affect the colloidal osmotic pressure. What is the alteration? That decrease the colloidal osmotic pressure, that leads to pleural effusion. Okay, now let's come to the atelectasis. Many of the lung diseases end up with atelectasis, collapse of the lung. When there is collapse of the lung, the pleural space is increased. That will increase the intrapleural negative pressure, which leads to accumulation of fluid, which increase the intrapleural negative pressure, because of more space is created. Now let's take cancer. If a cancer affect the lymphatic drainage by blocking it, by compressing it, then automatically the lymphatic drainage is decreased. That leads to accumulation of fluid in the pleura. So what you have to understand is these are the various clinical settings causes this problem, alters the mechanism that leads to pleural effusion. Okay, so once there is pleural effusion, what we do is we remove the pleural effusion, we see what type of fluid it is. If it is of transudate, like in the case of congestive heart failure, they produce, that is called hydrothorax. If it is of blood, then it should be the case of vessel rupture, trauma or cancer, that is called hemothorax. If it is of purulent exudate, full of pus, then it is in the case of pneumonia and pleural infection, then we call it as a empyema. If it is full of inflammatory exudate, serofibrinous exudate, then we call it is due to some systemic autoimmune diseases like SLE and rheumatoid arthritis. SLE means systemic lupus erythematosus. Now if the fluid is full of like milky fluid like this, and then we call it as chylothorax. It may be due to mediastinal lesion, mediastinal mass obstructing the thoracic duct. Thoracic duct is a major lymphatic duct. Okay, so that leads to chylothorax. So what we are seeing is, once there is effusion, then we take that effusion out and then we see what type of fluid it is. According to that, we can identify by seeing that what type of fluid, then we can name what type of the pleural effusion is, then we can identify the cause of it. So that's how it is very helpful. And we remove the pleural fluid. The procedure is called thoracentesis or pleural tap. It is an invasive procedure. We remove the fluid or air in the pleural space. Okay. Now coming to the air entering the pleural cavity, air or gas in the pleural cavity is called pneumothorax. It is most of the times traumatic, or sometimes it is spontaneous. If it is not associated with trauma, it is most commonly associated with these conditions like emphysema, asthma and tuberculosis. In emphysema, especially the bullous emphysema, Dr. Sylvester would have explained to you guys in the lab sessions that bullous emphysema, actually it is the emphysema occurring just at the periphery of the lung near to the pleura. So subpleural alveoli is affected. Then if it ruptures, then automatically the air enters the pleura. Actually once the air enters the pleura, the negative pressure is altered, which will have serious effect on the ventilation process. Okay, so our trauma can perforating injury to the chest causes direct air into the pleural space. So sometimes trauma pierces the to the chest wall, but sometimes trauma pierces the lung. So thus provides two avenues for the accumulation of the air within the pleura. One is from outside, one is come from the lung. So that's why we call two avenues for the accumulation of the air within the pleura. Now coming to the spontaneous idiopathic pneumothorax, which means we don't know exactly what is the cause of the pneumothorax. It is called idiopathic pneumothorax, which happens in the young people, and because for unknown reason there is some apical subpleural blebs, which is called small dilated air space that will rupture and that will cause idiopathic pneumothorax. Whatever it may be, that if pneumothorax comes, it will cause us atelectasis. That atelectasis is a compression atelectasis, then the lung will go for collapse. Okay, so this is the problem happens in the pneumothorax. Immediately you have to decompress, which means you have to remove the air from the pleura. That is the treatment for pneumothorax. So now coming to the pleural tumors, and remember the pleural tumors are rare, okay, but it may be benign and malignant. The pleura is lined by a cell called mesothelium. So the tumor comes from mesothelium, we call mesothelioma. Remember, mesothelioma means don't think it is benign only. It can be benign, it can be malignant. So malignant mesothelioma is very dangerous tumor because it is very aggressive tumor. It is very aggressive tumor. Most of the patients, they die within a year, and they always have some common cause, that is industrial hazard, most commonly asbestos. Okay, asbestos is the most commonest one which produce pleural malignant mesothelioma. Okay, this ends the pleural diseases.